Welcome to another Creating Collaborative Care webinar. This one today will focus on senior pet cognition, tips on managing cases, and the role of nutrition. Before I introduce our panelists for today, I want to give you a little bit of a word from our sponsor, the Purina Institute. The Purina Institute is all about bringing you sources of information about veterinary medicine and nutrition in a user-friendly, ready-to-access format. Check out Purina Institute's Center Square for lots of valuable information. Especially given that you're interested in senior cognition, you might be particularly interested in the cognition information specifically at Center Square, including the DISHA assessment tool and articles on canine cognitive dysfunction and understanding cognitive decline and the roles of diet in the senior dog. With that, I want to introduce our speakers. We have three absolutely phenomenal speakers today, each one with a different area of expertise. All of our speakers are internationally recognized as speakers, wonderful speakers, and experts within their field. They've all published great research papers and practical papers, textbooks, and so forth. So we know that they are going to bring us some great information today. First up is Dr. Julie Churchill. She is a nutritionist. Julie is a professor at the University of Minnesota. Julie's veterinary degree comes from Michigan State University. She did an internship at the University of Georgia and has a combined residency and PhD in small animal nutrition, which she completed at the University of Minnesota. She is faculty there. One of the things about Julie is she is just passionate, not only about nutrition, but also about helping veterinarians communicate about nutrition. Our next speaker is Dr. Lisa Radosta, who is a boarded certified veterinary behaviorist. She has her veterinary degree from the University of Florida, completed her internship at Coral Springs Animal Hospital in South Florida, which is my hometown neck of the woods. She completed her residency at the University of Pennsylvania. She is currently the owner of Florida Veterinary Behavior Service, which provides clinical referral and specialty care for animals with behavior problems. She's also the co-owner of Dog Nerds, an online educational resource. And our final member of the panel is Dr. Holger Volk. He is a faculty member, the professor of small animal medicine and surgery at the University of Hanover. He has his veterinary degree from Hanover, a PhD in neuropharmacology. In addition to his many honors, he is the chair of the International Epilepsy Task Force, which has in recent years published 7 different related consensus statements. So as I mentioned, all of these speakers are well positioned, they're well recognized, and they're going to provide us with a fantastic presentation today. But before we start, I have a few housekeeping tips that we need to talk about. One of them is that if you need closed captioning, you can click on the CC at the bottom of the webinar screen to turn it on. If you need technical support, you can click on the technical support button in the red navigation bar on the auditorium page, or use the chat bubble on the left side of your screen. You can also use an email address in the top navigation bar of the homepage or the auditorium page if you need technical help. During the talk, during the conversation, feel free to ask questions and send those in to our speakers. Place those questions in the question box to the right of your webinar screen and click submit. We will try and bring those up as we go through this discussion, and the ones that aren't covered during the conversation, we'll try to cover at the end. With that, what I'd like to do is get started by posing a question first to Dr. Lisa. Lisa, many clients think that cognitive and behavioral changes that they're seeing in their pets are just old age. How should veterinarians learn to distinguish cognitive dysfunction from other diseases, including structural brain disease, and differentiating that from some fear, anxiety, stress, or truly just old age. Would you start us off, please?
Absolutely. So here's the thing. The short answer is you cannot distinguish signs of either CDS or CCD. You might call it canine cognitive dysfunction or cognitive dysfunction syndrome. It's kind of all the same. We're going to use those acronyms interchangeably, most likely. You can't distinguish CDS from systemic disease really well. So the way I look at CDS is I think of it as, in vet school, how you learn to always put neoplasia on your list, always. Well, for a dog or a cat who's 10 or older, CDS is always on my list, always. What I want veterinarians to take home from today is not how do I distinguish between a neurologic disease and CDS, which is a neurologic disease, right? So the behavioral signs of CDS and, let's say, anatomical neurodisease, a brain tumor. That's not what I'm here to tell you. I'm here to tell you is look for the brain tumor, look for arthritis, diabetes, nutritional deficits. So the 10-year-old dog, the 11, the 12, most certainly the 15 or 16-year-old dog probably has some signs of CDS. They may be a normal part of aging, but what they most definitely have is some other systemic something, arthritis, diabetes, something else. So I want you to, instead of thinking of this as behavioral versus medical, I don't like that at all. We're going to say it's one animal, it's one medicine, alleviates signs of pain, fear, stress, etc., while you hunt down the list of things that are going on in this animal's body and do the simple, straightforward things at every first appointment with those 10 or 11 or 12-year-old dogs so that you slow the brain aging process.
Are there key questions that veterinarians should be asking that will help them in that differentiation process?
Yeah, so we use at our practice the Purina screening tool, and we have integrated it online so that I'm not getting any doorknob questions and so that my technicians don't have to take a full history for me. So we have it integrated online. The link is sent to all of our clients who are bringing in any age of pet. We put it into our regular questionnaire. And it's sent with the confirmation, how you text out your confirmations for appointments. Client clicks through that link, fills it out, automatically gets dropped into our system. So we have an ongoing score from that DISHA. And I know we have a slide, Dottie, I don't know if you can bring it up or not, with the DISHA scale. It is colorful and cute and easy to use, and it gives a number, which my clients in Southeast Florida, they like a number. And they track that number. What was the number last year? Oh, it was 5. What is it this year? 10. Oh, it's 10. And that begins the conversation of the number's different. Why is it different? What should we be doing? So we use this scale every day in practice.
Great. Holger, do you do anything different? Now you're seeing cases that are referred perhaps for other reasons or perhaps for the same clinical symptoms, clinical signs. How do you handle it differently, Holger?
I mean, Lisa, as always, she gave the perfect entrance to this. I mean, we have a CDS clinic, so we see specifically old age dogs, and as you guys know, I think one of the big challenges actually, and I'm really grateful to be on this panel today, is that a lot of vets out there don't consider an aging brain and don't know when a CDS. So actually, most owners come to us because they're worried and they heard about it and they read something in the newspaper and they come by themselves rather than being referred. So the first thing is, I think, it's something which is just a standard thing, like you do a nutritional questionnaire, you also should do, I actually think if the dog is over 8 years of age or a cat over 10, you should do some form of questionnaire. Germans do like numbers as well, I have to say. It's not just in Florida. Germans do like numbers, yeah. Saying this, when is normal becoming abnormal? And I think that can be rather challenging. So for one, and I also now, if you look at the DISHA, and if it gets to that point that it's really remarkable positive for CDS, they are severely affected patients. So I do think we have to have today a conversation when we should start perhaps earlier treating than when the dish up pinks up red, so to speak, right? I give one other thing to think about the neurologic cases. If you see a patient having an asymmetrical neurological deficit, like a Manners response is not working on one side, or the paw positioning is not working on one side, then you really think about structural brain disease. Yeah, if they suddenly have headaches or neck pain, think about structural brain disease. These are kind of the key features which happens. And other factors like Lisa mentioned, they normally affect metabolically the brain, very symmetrical, so you won't pick them up. But if you look, you think like, oh, they have CDS, do a small neuro exam, and at least check for any asymmetry. And if you find asymmetry, then think about doing some advanced imaging.
Okay, I want to put the DISHA slide back up for just a moment, and I want to ask Holger first, and then Lisa, if you want to chime in. Are there any differences when you're looking at this and using this tool? Would you use it any differently or ask the questions any differently if it's a cat versus a dog?
Fantastic. I mean, as you know, other people have different acronyms nowadays for that, because the vocalization part, right? And that's a difficult one. So vocalization also happens when you have a cat with seizure activity, because when they just come out of the seizure activity, they also vocalize, they meow. And actually, that's what owners then suddenly realize. They find the cat meowing, and then they go, oh, what's wrong? Saying this, at least in my experience, when they get cognitive dysfunctions, the meowing is often at nighttime, and it's a little bit more, they pace around, they have a problem with their sleep-wake cycle. So you can differentiate that from the epileptic seizures normally.
Yeah, so I wanted to offer two things, because Holger made some really good points that people don't bring their pets to us for this problem very often. So the problems, I'm going to see pets in I'm going to say middle to end stages of CDS. That's what I'm going to be referred. The patients who are not sleeping, that's the number one complaint that I'm going to see, exactly, because it really affects the pet parent. And for cats, of course, the number one complaint I'm going to see is house soiling. But so what's really important about that for our veterinarians to know, and any veterinary practice team members that are watching, is that 85%, so we have several studies that show that about 85% of these dogs with CDS go undiagnosed, and that they progress in about 6 to 12 months, and that many by 2 years, 18 months to 24 months, have been euthanized. Now, whether they've been euthanized for systemic disease plus CDS, those are things that particular study that I'm referencing did not kind of elucidate. But what you also need to know is what you already know, is that they're talking to the next door neighbor and their mom and the person at the pet food supply store before they're talking to you. That's why you have to screen and really just integrate it into your normal screening for every single patient. And then the other thing about the differences between dogs and cats. So there are several different scoring systems for dogs that have been validated. This is the easiest one to use in primary care. So that's the one that we like to use too, because what I found, especially since COVID, is our clients are really not into a lot of extra work. They like to get it done. And this is a simple thing they can fill out. In cats, there's this acronym called VISHDAL. And this is why I'm telling you, just use the DISHA scale, because now you have to remember VISHDAL, right? So it's vocalization, altered social interaction, sleep-wake cycle, house soiling, disorientation, activity, anxiety, learning and memory. It is definitely complete, and that's lovely and beautiful. But the average client, if they give you a score on the DISHA scale, it will lead you down the right path where you can ask more questions. So you've got to be asking, you've got to be screening, and this will cover dogs and cats. And if you're a real, CDS geek like I am, and I'm just going to throw out Holger is CDS nerd, then you can look up these other scales that you can find in publications. Absolutely.
Yeah.
Beautiful. And this DISHA scale and the scoring, I believe you said, are available at Purina Institute Center Square. So if our audience wants to download it, they can do that easily.
Dottie, may I interject one thing, just because Lisa obviously said something, but what I think would be really useful if all our colleagues out there would actually do this for a pet they had. And then the one thing they should think about, if this would be a human being, what would they show? And then you realize that we are probably a little bit late in the disease process. So, rather start earlier. So when you see the numbers creeping up, then too late. Even if the studies, obviously, if you look at the studies, they always take a severe affected pet to see if they improve. But, and I think Lisa would also agree with that. You rather start early than too late.
Yeah, with everything, right? Prevention is so much easier.
Yeah. So the neurogenesis goes down, when you get older. So you don't have as many neurons building anymore. And obviously, what you have lost is lost. So you can't go back.
Well, thanks for putting a sunshine view on my aging process.
No. We are all very mild.
Okay.
All right. Before we leave the topic of diagnosis, so we've made the diagnosis using the DISHA score or other evaluations done on a regular basis. Once you've made that diagnosis, what tips can you share for our audience for them to make it easier for them to communicate to their clients about this condition? What tips can you share with them? Lisa, why don't you?
Okay, I'll start. Yeah. So I am a storyteller. And so in the exam room, I try to draw analogies between my life or that person's life. So I teach my residents to read the room. And if I have a person of my age, I know that they have already experienced memory loss. If they're in their 50s, they're already looking for supplements to be less painful or to help them with memory, et cetera. If I have a 22-year-old in the room, I'm talking about her parents. And so I just try to read the room. Who am I talking about? And I just say, hey, I've noticed in my life that sometimes I can't find my words. And a person of my age will usually start laughing and say, yeah, what is that? What is that? I cannot find my words. So we talk about just that aging for a minute. And then we talk about the numbers. And then I say, just like I take supplements, B12 as I age and things like that, right, for human beings, I have several supplements and nutritional options, so diets that I want to recommend to you so that we can potentially slow the aging process. And then I explain what's in them. I don't like to hand things out and just say, give this to your pet. I explain this is what's in it. This is what it does. This is what it looks like. It's a capsule or a tablet, because if you have a 5-pound teacup Yorkie, the first thing the pet parent says is, how big is the capsule? And how am I going to get that in, right? So I explain that to them, and I have my practice spiel like everybody does. And that is kind of my first bit of the discussion, drawing analogies, talking about ourselves and our families and how we feel as we age, right? And the things that they know. So I say, I know that you play golf. You're in your golf outfit. I bet that keeps you really young. Well, guess what? Did you know that you can slow the brain aging process in dogs? If you teach your dog a trick once a month, can you believe it? That you can change your dog's brain? Well, when it's sold like that, they're like, heck yeah. Why wouldn't I do that? Why wouldn't I do that cool thing for my dog? So that's my approach.
Beautiful. So before we start talking about management, Holger, other thoughts in terms of communicating the diagnosis?
No, I obviously I have to come to Lisa and see what she will tell me when I come into the room. I'm looking forward to that. Anyhow, just some additional things, because definitely in Germany, what we see is that most people will tell you they're slowing down. We lost a lot of words about CDS, but we didn't speak so much about the other comorbidities, and I don't want to go too much into detail there, but most people do confuse osteoarthritis, a dog, which is a bit more stiff, with actually a dog which might have also CDS. And Lisa said it beautifully in the beginning, but at the end of the day, it's like a Cavalier King Charlesman with mitral valve disease. The question is not if they get it, the question is when they get it, and the same happens with dogs. Even if you have veterinarian colleagues, and I had just this 2 days ago, I was here at administration at the vet school, and she said, yeah, I have an old dog. And I said, oh yeah, we have this clinic and we look after, cognitive dysfunction. He said, oh yeah, don't worry. I'm a vet, and my husband is a vet as well. And I was like, oh, okay. And he was a really aged dog, And then we moved on, and we had a little bit of conversation. So I hope no one from the admin listens, because the dog was actually in the tower, so they're not allowed in the tower. And then suddenly the dog was, oh, it lost some feces, and I was like, oh, that's a really interesting thing, right? And she did not recognize that her dog already was affected, because he only said, oh, he's a bit stiff when he gets up, but still hungry and still eating a lot, and it's all fine. That's not fine. And that's why I said earlier, you need to do the Disha score once for yourself. Other comorbidities are also important, and they are the ones which you guys normally are very well in picking up. You're very good in picking up kidney disease, in blood pressure. Most people will do blood pressure routinely now in cats. Definitely do it also in dogs. You will be very good in picking up the polyarthritis affecting them as well. Them being stiff. But think next time about also CDS, and have the questionnaire, and then have those conversations, because as earlier you start, the better.
You and Lisa
can I just
have
throw
both...
one thing out, Dottie? I know,
Sure.
I really something. Oh my God. So listen, here's the thing that I want people to, I'm really, the year 2022 is my one medicine year, where I'm really trying to teach about not distinguishing, but instead treating and looking for everything. So I want to just throw out a statistic. There was a recent study done multi-country. So it was an international study with centers, veterinary behavior centers in different countries. There were 6 veterinary centers. And the group of researchers looked at the number of animals presented to veterinary behaviorists who had gotten through the referral system. They had been referred by a vet, okay? The number of animals who had undiagnosed systemic disease or orthopedic disease. So they were lumped together. So vets in the audience, think about what numbers in your head. Okay, so 23 to 86%. 86% of those animals were sick. So I'm not saying CDS doesn't occur, and I'm not saying you should ignore behavior. Quite the opposite, because behavior is the specialty that really permeates every other specialty, because pretty much everything is behavioral science. That's the way I think, right? But I'm in the cult. But anyway, the point is, you have to hunt it down. So if you can't examine the cat, and you're going to send home meds so that the cat can come back and be examined, you're going to find a way to sedate it that day to get RADs. If you can't figure out if he's painful orthopedically, which he is, because 90% of cats over 10 have undiagnosed orthopedic disease, then you're going to sedate him and take the RADs. You're going to do a trial of one of those great pain relievers we have for cats. So you're going to hunt it down. And I hear you when you say clients push back, because I feel the pushback. My dog's not painful. Well, he has trouble getting up, but he's not painful. So, I understand I have that pushback in my exam room, and I have my ways of getting around it. And I don't always get the client to do the diagnostics, but that doesn't stop me every day from getting up and trying. You have to hunt it down, and you have to presume illness and then prove otherwise with older animals.
Thank you. Holger, both you and Lisa have mentioned starting the DISHA evaluation early. And an audience question has just come in relative to that. And it is, if you wanted to see a benefit or preventive study in dogs and cats, what would be an ideal age to start scoring patients? So thinking about it, when does cognitive dysfunction start? And I'll start that to Holger. In dogs and in cats.
Yeah, I mean, there is some data, for obviously dogs are very varied, right? But if you take the global dog, some people say around the age of 6, they might start getting affected. Saying this, what we normally do is up from the age of 8 in the dog and 10 in the cat. So that's,
I think we have a slide on that.
Yeah.
Let's see if we can bring up that visual.
So, this is a great number to have. If you have a 12 to 13-year-old, 1 in 3 dogs will be affected, and a 15 to 16, 2 in 3 dogs. But these are obviously severely affected pets, right? And you want to have a baseline, right? Like, I'm getting in this age where you have to look for your prostate, right? So you want to have a baseline before you at one stage probably get disease. And the same is for that. So do start early. I think that's the take home message.
So what is early? And do
For
we have
me,
similar
I
data
start in dogs in 8 years and a cat in 10 years.
Okay.
And obviously, if I have a Great Dane, obviously 8 years is, oh, well, that's quite good, right?
Yeah.
But if I have the normal Florida patient, I guess, which is more the smaller dogs, then obviously 8 is totally fine.
Okay. And if we can bring up the next slide, just to have a relative situation for cats.
Exactly.
Same situation, I assume. We have a prevalence, but it starts
a little
before
bit later.
this.
Yeah, exactly. Lisa, any different thoughts on that?
No, I mean, I'm in a complete agreement. I just want to, I guess, add that we say, so I do the same as Holger does, right, with the ages. And the reason I think Holger probably mentioned 6 years old is because in laboratory studies where animals live in the lab, where their behavior is measured as a part of every day, changes are picked up in dogs as early as 6 years. But as pet parents, I'm a pet parent too, we don't all the time notice those subtle changes. But when a cat or a dog lives in a lab, their learning is being tested on a regular basis, right? And so we know the changes are happening around 6, but you're not going to find them if you're not looking for them, because pet parents probably aren't going to recognize those changes.
Okay. So Lisa, once you have recognized a change in cognitive function, what's your first line recommendations? How do you start them off in terms of therapy? And now we don't want to go into a lot of detail on this, but still top of mind, what's your first line recommendation for?
Yeah, there's 2 categories, right? There's the category of dogs 10 or older. So in our practice, the way we practice, if dogs are 10 or older, regardless of whether they have signs, we recommend 2 supplements that I think are in our resources, Dottie, I think that are backed up by research in dogs. And we recommend the 2 diets that are backed up by research. So that is 10 years or older. Doesn't matter what your score is on CDS. Why not protect the brain? It's a really important organ, right? So then there's the animals who come in who have an actual problem. I'm going to call it behavioral pathology, even if that pathology is caused by some other body system. So while we're hunting that down, what do? Same thing, 2 supplements and diets, if they can be recommended. And we always recommend, of course, environmental enrichment. But what extra do we do for the behavioral pathology? We identify the stressors for the pet parent and the pet, and we try to change those immediately. Okay, so pet urinating in the house is a stressor. We're obviously working that pet up. We're doing an orthopedic exam, a neurologic exam. We're doing lab work, urinalysis, et cetera. But I am also putting mats down on the floor of the house, yoga mats, so the dog can ambulate to the back door to go to the bathroom. I'm asking for an image or a video of the dog going to the bathroom. You wouldn't believe how many dogs can't squat anymore, and cats can't get into the right position. So I'm asking for that stuff. And then I'm treating the exact problem the client came in for to the best of my ability. If it's sleep problems or waking up during the night while we're working the pet up, I'm going to choose anxiety relieving medications that help the pet sleep, that would not interfere with my testing. And this is where you got to pick up the phone. You got to get on the phone with your local vet behaviorist. If you give trazodone, it might affect your testing for Cushing's. You got to watch what you do, right? So maybe I would discontinue that the day before if I'm using it for overnight. So I'm going to prescribe immediately because I'm here to give you the frank truth. You're going to wake up some days and those pets will have been put to sleep by another veterinarian as you wait to do things in a systematic way. So as long as I'm doing no harm, I directly treat the signs that the pet is there for if I can.
Great. Holger, do you do anything differently?
No, this is exactly why I signed up to do this, because I'm already learning a lot. So, and I would like to know from the other 2 in a second. So we do the same. I mean, we start with nutrition. We start with environment enrichment. We have even a created little Facebook page where, people can do some exercises. We show them what they can do. Exercise is really important. We have shown that it's improves the neurogenesis. There's a lot of studies on that. I again, being the clinician, from a neurologist point of view, I do look at other diseases. They might have some back pain, some lumbosacral disease. They might have some osteoarthritis. So I do think it's really important to treat them as well, because often the pain is not only just laying down or not, but we did a really interesting study where we put accelerometers on dogs, and I assumed that dogs would move less when they're older. But it's actually the opposite. They constantly move, and it makes totally sense if you think about it, because their joints are stiff. It's like when you're getting older, and definitely I'm starting. You shuffle more in the bed, right? My kids, they just lay there, and I shovel. Saying this, but then when they run a lot, right? And then they lay there again, right? So they have a lot more really active exercise and then a lot of rest. And in dogs which get older, then they get more stiff. They don't sleep so well. Because they don't sleep so well, they perceive pain more. We all know this, right? If you had a couple of nights no sleep, there's two things which gets affected. The pain, you feel more because the thalamus feels a bit more. And the second thing is your cognition goes down, right? And that's why sleep is so important. So the interesting thing is, Lisa, we do a slightly different. So yes, we do the nutritional aspect as well. But I normally don't go to trazodone. I normally go to gabapentin, so we treat the osteoarthritis pain. There's different ways of strategies you can do this. But I also like to give them a higher dose of gabapentin in the evenings. That helps a lot with the neuropathic pain and the pain parts, and also helps with sleeping. That's the only thing what I would have done differently.
Yeah. And that's really important to say, because there's behavioral meds out there, but the ones we're going to see vets reaching for the most, and I call it a behavioral med, gabapentin. Yeah. It's a neurologic, like it's in everything. It's a pain med, right? So gabapentin and trazodone and maybe clonidine, they're going to be reaching for. And the way you're going to distinguish between those meds from a behavioral standpoint, which one should you use for sleep? So we're assuming the pet's there's not another reason to prescribe trazodone, gabapentin, or clonidine. So we're just assuming we're doing it for sleep, is going to depend on a lot of different things. So I don't want you guys to come away with the impression that there's one answer, because there isn't. If I have an orthopedic dog, I probably would use gabapentin at a little higher dose just at night. But when do you dose it? You dose it an hour and a half before the pet wakes up. You have to be really strategic. So if the pet, and then you have to think about orthopedically, how am I going to dose it for best pain relief and find the best place. So for example, if the dog wakes up at 2 a.m. and your pet parent doses gabapentin at 6 p.m. with dinner, it's not going to help that dog continue to sleep. Okay, so we may want to give our regular dose at 6 p.m., bump up the dose somewhere around midnight when the pet parent goes to sleep. It's beginning to really have an effect somewhere around 2 or 3 hours, the pet parent sleeps. So you want to get the time, because CDS dogs are so cool, and cats are amazing this way. There's a time clock. They wake up at 2 a.m. The cats especially, every morning, it's 2:12 a.m. So then we can dose these pets in a way that helps them to sleep while paying attention to our drug choices, which should be based on, as Holger pointed out, other things as well. And I really am interested to hear Holger's take on this. Am I taking over too much, Dottie? Can I ask him a question?
A quick question, because then we need to start talking about nutrition.
Definitely.
Okay, quick question. So, Holger, I have seen twice in my many years of being boarded, dogs that I put on gabapentin at doses I felt were reasonable. And, as vet behaviorists, we go quite high in dogs and cats, and on a reasonable dose, who then presented back to me with signs of CDS, which weren't signs of CDS. They looked like that. Then my personal life, I saw the same thing in my stepfather who had vascular dementia. So have you ever seen gabapentin? It's not that it worsens CDS for all the vets out there. It's that it can produce signs similar to that, but I've only seen it in the elderly. And I would love to hear how Holger feels about that.
I mean, you're perfectly spot on again. And when we use in younger dogs, I use gabapentin for back pain. I use it normally three times a day. Just in the older pets, I often use it at nighttime, because I know it has also a sedative effect, and that's what I obviously want to have. People use it also for sleepless leg syndrome in people. And so, if you use it at nighttime only, normally you are fine. Apart from if you have kidney disease. So gabapentin obviously get excreted through the urine. So if you have also underlying kidney disease, you need to be reducing the dose, and that's what could happen. Yeah.
All right.
Thank you.
So I want to get back to something that Lisa mentioned, which was she recommends dietary management based on products that have had research. So I want to finally bring Julie into this conversation. And Julie, I want you to share with us cognitive diets for dogs with cognitive disease. What are the different characteristics of the diets that are supported by research?
Yes, thanks, Dottie. Well, as most people know, there are really only two therapeutic slash prescription vet-directed diets for cognitive dysfunction. And they have some similarities, but they also have some significant differences. And so what I look at first is what I call the base diet, the macronutrients. And that's where they vary quite dramatically. In that the one that I use most commonly, because these are senior pets, is one that has a normal to slightly higher level of dietary protein, and it is enriched in fats, but a specific type of fat.
I just want to clarify. You said for senior pets, you prefer a higher protein diet.
Healthy senior pets without organ dysfunction, I absolutely do. There's a
Thank
lot
you.
of evidence that shows they actually have higher dietary protein needs, and that can help minimize or reduce sarcopenia, or the muscle loss and contribution to frailty of aging.
Okay.
So the diet that I would draw from most commonly in a otherwise healthy senior pet would be, it's a normal to slightly higher than average dietary protein. It's enriched in a specific type of fat, a medium chain triglyceride, which again is a secondary preferred fuel source for the brain. It also has a blend of antioxidants, B vitamins, and omega-3 fatty acids. And so that is the one of the therapeutic diets. The other, and it has evidence, again, it's been shown at the Canine Cognition Lab, studied that they saw some visible improvement in as little as 30 days, and then even more improvement up to 90 days later. The other diet is different. It also has a milieu of antioxidants, but it is much lower in protein and a little bit lower in calorie density. That isn't my first pick because it doesn't meet the protein needs of many of my geriatric patients. So there are pros and cons to both of those. I think they both have shown evidence to be helpful in dogs that have shown cognitive decline. They both, under the right conditions, they both showed cognitive improvement when eating those diets. But really, I'm going to be doing a nutritional assessment and seeing that I meet the whole needs. Like Lisa said, we're looking at the whole picture, and I'm not just feeding a brain, I'm feeding the whole senior pet.
Okay. Well, let's build on that for a minute and step back from cognitive dysfunction. And when you're talking about senior pets, obviously they all have something going on, right? But what are your primary concerns with the nutritional care for senior dogs and senior cats as well?
Great. For both, I want to optimize water, because we know, especially in our cats, they don't like to drink very well. And as we all get older, our ability and sense of thirst declines. So I want to make sure I'm doing everything I can to make sure they're both well hydrated. Dogs are kind of dumb sometimes, so I'll put water right in their food. Trickier to get water intake in cats. I do increase dietary protein. Again, you want to do a full health screen and health assessment and make sure that dietary protein, increasing that there's no contraindication, no underlying diseases, liver disease or kidney disease, that would make that an unwise choice. Otherwise, I will increase the dietary protein 1.5 to up to 2 times what a young adult might need. Again, paying attention to lean muscle mass and trying to support that preservation of muscle as much as possible. And well, those are the main, and then really the other thing to pay close attention to is to optimize body condition and muscle condition. And so to tie that into what Lisa and Holger said, arthritis is highly prevalent in our senior pets, whether they have CDS or not, and it confounds our ability to assess mobility, their ability to get to food and access to many other qualities of life. And so I want to optimize body condition. Elder dogs are more likely to be overweight, and that compounds all the inflammatory mediators, so throughout the whole body system. Cats in their early years of seniorhood might be overweight, but as they get very advanced, they're more likely to be that, I call it skinny old cat syndrome. And so then I want to pay attention that I'm really meeting their caloric needs to arrest any unintentional weight loss.
Okay. I'd like to bring up a slide on the circle of nutrition, on nutritional evaluation. And I'd like you to kind of take us through that with particular, the cognitive patient in mind, and how that might differ for a cognitive patient than for a healthy senior pet or senior pet with other maybe comorbidities.
Yeah, so full disclosure, I do this circle of nutrition or this nutritional assessment the same for all patients. I will, so it isn't really different for dogs or cats that I suspect with CDS. And my hope and dream would be that we would do the dishes scale even before. I might be a little earlier adopter to just tell clients it's a middle-age baseline, because I'm going to be doing a health screen then at that time. It also plants the seeds, in my humble opinion, for things to watch for. So if they haven't seen that, then they're now being mindful of the things. So for the animal factors, I want to just do a full health assessment. And that includes sort of what is their age status, at what stage along the senior and geriatric spectrum, what are their other health factors or comorbidity. I would certainly add the DSHA scale along with that, to be really paying attention and mindful of all of the things that tend to happen or increase frequency as they enter their geriatric years or senior years. Dietary factors, I want to do a really thorough diet history. So I want to know what they're eating now before I make a change, because sometimes they may be eating a diet that has many of the components already. A lot of owners are very cognizant of the importance of omega-3 fatty acids or fish oils. So it may already be in the diet. And before I add a supplement, I really want to know where I am, so I'm mindful of getting the right amount and not overdoing it or underdoing it.
How do you collect that information? Do you use a diet history form, and how do you manage that?
Yeah, again, because primary care, it's busy. We're all busy. And so how can we make this efficient and easy for clients? Because like Lisa, nobody wants any extra work. I have the luxury, but I would make a big pitch that there are wonderful diet history forms. And I think you're going to show one. There's one on Center Square, and the WSAVA has a lovely short one to download. We have ours digitized, like Lisa has the dishes score digitized, and we send this out when we send our client reminders. So here you are, so that they're at home with the food and they're not in your office going, oh, it's the purple bag. So that they're looking at it. They take a cell phone shot of exactly what their food label might look like. We ask again, so that they come with that. That makes our job more efficient, but it also does this really lovely sort of secret thing. It positions us as the nutrition expert, the askable professional. So they're not going to the pet food store. It prompts them that we are the people that we care about the nutritional care of their pet, and we're the people that you should be asking those questions.
Okay. And I'll let you take briefly to continue that circle of nutrition and close that up, and then we'll move on.
Great. If we'll go back. So again, we thoroughly assess the health and physiologic state of the animal. We look at all of the dietary factors, and that includes treats, because that's such an important way in the way we relate to our pets. And it can be as much as 30% of their intake, very commonly in the animals that I see. So I want to make sure that I'm leaving them also with a treat plan. The environmental factors are are the pets confined to the house? Are they go on leash walks, or do they get to roam free and get treats from the neighbor's house? What are the other animals in the house? That are they eating cat food, dogs eating cat food, and vice versa? And then the human factors. If we don't attend to our partners in their care, which is the client on the end of this circle, then we will be doing a disservice. So it's really a partnership. And if I recommend something that doesn't sit right with the family's feeding philosophy, it's a fail. And of course, this is an iterative cycle. So I make a recommendation after this assessment, and we go around that circle again to see if we had the expected results. And if not, we go back and re-examine it. And this is a process that happens at every visit, every time.
Great. All right, we're getting a lot of questions in about a couple of things. One is how to have these communications with the owner, whether it's about dietary recommendation or treatment recommendation. And I want to get to that in just a moment, because we're also getting questions about how to differentiate the comorbidities. What are some additional tips for veterinarians to help differentiate the comorbidities that are often confounded or concurrent with CDS? So diagnostic tips. Why don't we jump to Holger to start that, but anybody can jump in after.
I mean, because the word comorbidity sounds like these diseases which are beside each other, but often they feed each other as well, right? So if I have a vascular disease, so when I studied veterinary medicine, no one thought you could get an infarct, no one thought you could get actually problems with your vascular structure. Nowadays, we know you do. And when you get older, we see, as in people, a little bit of white matter disease, small vessel disease, which then causes small infarct. So as we age, we have one infarct every 10 years, which is very normal. So if we do an MRI scan of us, then we will find some small infarcts. Same happens in pets. We used to only MRI young pets because that's when people said, oh, let's do this. Now we have a different human-animal bond. People are more willing to spend money also in the, not only probably in Florida, even in Germany, where they get older. And then you suddenly start seeing that they all have some problems also with their vasculature and their blood perfusion. So often, especially in cats, obviously we all have it, but also in dogs we have that. The polyarthritis, I think most of our colleagues will be very well equipped, and that has been discussed in veterinary medicine for a very, very long time. It becomes a little bit more challenging with kidney disease, and I would definitely like to have the other people's opinion as well, because when you then come into how you treat them, sometimes that can be conflicting with what we have on hand. But I wouldn't see it as, this is typical only CDS and all the other ones are not there, because it's an old pet. They will have multitude of things. So you have to tackle each of them, and then obviously make sure you don't have drugs interacting, or you have nutrition, and I'm not expert on that, which might aggravate one of the conditions, as example, as kidney disease.
Yeah, so I would suggest what we do in our practice, and I like efficiency and technology, and my doctors seem to appreciate it, is we have a standard kind of older pet workup. Exactly. That we recommend. So then you're going to start the process. So if you're thinking, how do I tell if it's CDS or if it's neuro disease or if it's internal med, don't worry about that at the first appointment. You got to pull a CBC, a chem, a free T4 by ED. You got to do a UA, and you have to do a fecal antigen plus Giardia, at least in the US, because we're swimming in it. There are case reports that link stargazing to Giardia. There are case reports that link circling to Giardia, non-clinical. There are cases that link pica in cats to Giardia. Like, it's the root of all evil as far as I can tell. So we want to be looking for, that's your standard. And your standard is to do an orthopedic and a neuro to your comfort level. So I'm at a specialty level. I'm going to do an orthopedic till I get pain. Then I go, oh, there's a surgeon there. I'm going to do a neurologic till I find a sign. Then I'm going to go to the neurologist. That's my comfort level. I found enough that I feel really comfortable referring. If you want to approach it a little differently, you can look for things that occur commonly. So we commonly have found dogs with Addison's, Cushing's, and hypertension to show signs of CDS. I don't love that approach. I'd rather you be systematic. I'd rather you have a workup that you go through. But if you're thinking, I have to explain this to the client, and it looks like I'm throwing this blanket of tests on their pet, you could start the process by looking for what you know is highly likely. Pain is the number one thing I'm looking for with when a dog or cat presents with CDS. Pain. Number two, I got to do my blood work. I have to. What if the cat is hyperthyroid? Number one cause of vocalization overnight, hyperthyroidism. Okay, so I'd rather you be systematic, but I totally understand if you don't want to throw it at the client, then keep the systematic way of approaching it in your medical record and check it off through each appointment, so you make sure you get all of those done.
May I add one tiny thing to this, because I'm just a fan of urine, and there's a couple of reasons for that. But the way I was trained, and David Churchwell will be very happy with me. But joking aside, obviously with kidney disease, you get changes in your urine, and as we all know, and now you've all had grandmas, and suddenly they get confused. The first thing you look is, do they have a UTI? And there has been some nice papers now, also from a former group, where we also have shown that urinary, infection can actually aggravate neurological conditions you have, or if you don't have anything, also your cognitive function. So the first thing I always do if I have just to do one test is actually look at the urine. It's very simple. Look at the sediment, take the protein, and so on. It's not difficult to do. Very cheap.
That's great. Okay, we're starting to run out of time. We have an important topic that we haven't touched on yet. But before we get to that, Julie, very quickly, generalized thought process, comorbidities. You have you want to give a cognitive diet, but you have an obese pet. You have a pet with kidney disease. You have a pet with diabetes. How do you balance things?
That's a great question, because the older you get, the more likelihood you're going to have those comorbidities. And so what I do is a little bit of what I call nutritional triage. It's really identifying what are the health problems and which ones are impacting the quality of life the most, or which ones are more likely to be rapidly progressive that could result in the demise. And that's how I make my priority list. I would choose the therapeutic diet that meets the geriatric needs, the one with MCT oil, if cognitive dysfunction is the top, the cream, and they don't have any of those other problems. If they do have other problems, then I need to see, are there any nutrients in there that are a contraindication? I know there was a concern of pancreatitis, but again, that MCT oil doesn't really impact the triglyceride profile. And so maybe I wouldn't start that in the middle of an active case of pancreatitis, but it doesn't condemn them forever. One act of pancreatitis doesn't condemn them forever for not being eligible for the cognitive diet. If they have significant kidney disease, I wouldn't use that diet. I would use the other therapeutic diet that's a little lower, that is lower in phosphorus and sodium, and would meet those needs. So I go through that process. If neither of those diets fit the needs or comorbidities of the individual, that's when I tend to draw from the supplements, because I know that I can do something for the pets while I'm maintaining the other comorbidities health-wise.
Great. Thank you. Thank you. Okay. I want to jump to a different condition, because you mentioned that, well, anyway, the bottom line is cognitive dysfunction is not necessarily a terminal condition, but eventually there are end-of-life issues that need to be discussed. And I'd like to take about 5 minutes or 7 minutes and really cover that, how to have those conversations, what are the best tools, what are the best approaches. And I'm going to let Lisa start this, but Julie and Holger, you jump in because this is something that's important to all of us. And I'm also going to get this slide up on the 5 freedoms, because I think that'll facilitate this conversation.
Yeah, so there's two different discussions. One is the discussion I have when I actually feel like a diagnosis can be made, that I have worked this patient up and I feel like we are at the point where CDS is most likely real and it is affecting the pet. And then we have a discussion of, we can't beat this. We can slow it, but I can't beat it. It's going to progress. And eventually, with all my efforts, it will win this fight that we're in. Okay, so we need to just come together on that. This is not something I can absolutely cure your pet of, but we can slow the process. And what that looks like is today, enrichment, diet, supplements, and medication for that particular problem. Let's just say, for example, right? And then I'm going to recheck with you at this time. And over the course of the next 2 years, there's probably going to be more meds. We're probably going to switch meds. If it's a pet who's waking up overnight, I immediately say in that first conversation, I immediately say, this is how it's probably going to go. We're going to tweak these meds. We're going to get your pet sleeping. And then in 2 months, your pet's not going to be sleeping anymore. You're going to call me back. You're going to come in. I'm going to give you a different med. And that is probably how the next 2 years are going to go, where we are going to be trying different things. It's not a big deal. I don't want you to be stressed about it, but I want you to know what's probably coming. Then there's the end of life conversation. This is a pet who probably has signs of CDS plus heart disease, renal disease, et cetera, right? Neuro disease. So then we talk about the 5 freedoms. And I have just a little schematic that I made with like 5 circles that I can hand right to the client. We print it out, we hand it to them. And then as I have the conversation, it's in their hand and they're looking at it. And I say, let's see how many of these freedoms that we can provide. These are the base needs of any living thing. Me, you, your dog, your cat, your bunny, we all should have these things. And as we go through them in a systematic way, it can be heartbreaking because you see the recognition and on the pet parent's face as he or she starts crying that even though they're making their best effort, and so am I, and so is the primary care, we're really not providing the 5 freedoms like we should. And I think it helps them to kind of get in the mindset of quality of life because they're so focused on eating and drinking. He's still eating and drinking. And I always say, that's a really low bar. That's a low bar. Let's talk about some other things that we can use to provide the best quality of life for your little one.
Holger, thoughts?
Yeah, I think, the only thing, having had an Irish setter, which I often use in my presentations, because she also had epilepsy, but also had cognitive dysfunction. And I also have to say, this is a difficult journey because, Beauty was at the end 17 years of age when Irish setters are quite old. And yes, you have these conversations, but often, suddenly they perk up again. And then they have a couple of days, where you had made the decision and then suddenly they perk up and then you're like, oh, and,
Yes.
and so it's a process and you have to have these conversations over and over again. And one of the things I think is really important that the owners don't feel guilty. So take them with you on the journey and, it takes time and they will know when it's the best time for them.
Great. Julie?
Yeah, like the stories Lisa likes to tell is part of my middle age screen. I also, and I love the freedoms, but I also have clients record, capture the essence of their pet. Clients love to do that, and then whether it's the frisbee or what fills them with utter joy, and then just to put that away. And then as they age, we pull that out and we ask, are they still able to enjoy those things? It fits nicely with the freedoms,
Yep.
but it's very individualized to what that family felt was the essence of that pet. And it helps start that conversation with empathy and, again, utter support, because we are the guide by the side as we help them through that decision.
Great. Thank you all very much. We're going to go ahead and capture a couple of the audience questions. A couple people are interested in knowing the names of the supplements and the diets, and I wanted to share that there's resources provided for all participants, and that includes the names and information, as well as some references that people might find of interest. So look to the resource sheets for that information. One of the questions is, how do we nutritionally manage cognitive disorders in cats with or without comorbidities?
It's a great question. There's just not very much information specifically in cats, so we need great research. There are some early studies that suggest many of the same things from the standpoint of antioxidants, omega-3 fatty acids, B vitamins have been shown to be helpful, but they're not in a commercial product. I'm really reluctant to say add this one supplement, because just adding a supplement doesn't create the brain diet, if you will. And supplements, as you many of you know, are not well regulated. So again, when I'm recommending a supplement, it's very much in a specific way with a specific name, or I direct my referring community to consumerlabs.com, which is an independent testing agent, again, and they're looking at purity and quality of supplements.
So there are 2 supplements that are in the resources that you guys will find in the resources that we recommend that have research studies behind them. Now let's talk specifically about cats. So one of those supplements is, I'll just say the name, so you'll be able to understand what I'm saying. Senilife is labeled for use in cats. There's no efficacy study in cats. There are efficacy studies in dogs. You can't just buy those supplements and put them all together and make a stew and hope for the best. So if you have a supplement that has research behind it and it's got certain ingredients at certain amounts with quality control, please do not try to replicate that at your local drugstore. Okay? Please get the veterinary branded supplements. So the ones we put in the resources are the ones that are veterinary tested, branded, quality control. The other thing is SAMe. Now, SAMe has, in fact, been used in cats, and cats and dogs have improved executive function when taking SAMe at appropriate doses. And so SAMe, again, you could buy it anywhere, right? However, I really want, in my practice, I only ever recommend a nutraceutical from a company that I trust that has research, because it's quality control and it is safety for my patients. So when I talk about supplements, I want to be super clear. I'm not talking about sending the client to a drugstore to get a bottle of something. I am talking about a product that has a technical services veterinarian that I can call, for the company that has research behind it. And that's why I only stick with the 2 that you're going to find in the resources. And for cats, you can use both, okay? But only SAMe has demonstrated changes in executive function in cats, to my knowledge.
Can I add something to that?
Yeah.
Because obviously it's about the individual patient as well. And I would just recommend you guys to go to a nutritionist, to get a balanced diet, and they will help you. And there's, if there was one thing during COVID, which is great, is we have a lot more online resources and a lot more online abilities and teleservices. And the other thing is, when you guys look through the resources we provide, is most of the research has been done on old aged, so dogs which have been aging, and was an aged beagle, and then they did dietary trials, but there's only very few products which have been done on cognitive dysfunction, and so that's one of the reasons I mean various reasons why I like medium chain rich diets, I have to say.
All right, we have one last question, and it might be a quick answer. I don't know. But do any of you notice differences by breed when you're doing your scoring for cognition?
That's great.
I have not.
So which is a dumb dog is the question, right?
Stop.
They're all great. They're all very smart.
No, you don't. This is the behaviorist talking. You don't want the smart one. You don't want the smart one. The dumb ones don't come to see me, by the way. It's only the smart ones.
All right. I'm going to ask our speakers if there's any final comments that you want to make that we haven't had a chance to cover. All right. With that, I thank you so much for your participation today. To the audience, I hope that you found this to be an interesting approach to this topic and found it educational. I have just a few closing comments to make. So again, thank you to our sponsor, the Purina Institute. I would like to let you know that there will be another collaborative care webinar on July the 14th. That's our next one. And that will be addressing client questions and concerns, tips for guiding clients to credible information on pet food. And finally, I'd like to invite you to sign up for scientific communications from the Purina Institute and go to Purina Institute Center Square for all kinds of valuable information to help you learn about nutrition and tips to communicate with your clients about nutrition. With that, I thank you very much for your participation. Here's the final announcements. This webinar will be available on demand. CE certificates, I'm sure you all want those and want to know how to get them. Those of you that have been participating live, you will receive those within 3 days via the email that you registered under. If you participate as an on-demand attendee, you will receive it 1 week, up to 1 week after you watch the session. If you need more information about the Resource Center, you can find it in the red navigation bar. And we ask also that you would provide feedback. Please take a couple minutes. Your opinion is very important. So click the survey in the red navigation bar to access it. And with that, again, I thank our wonderful speakers and I thank our participants for joining us today. Bye-bye.
Thank you.